So we'll move on to the next segment, which I feel is the most challenging scenario, that is management of substance use in criminal justice system and sexual minorities. Luckily, we have eminent speakers and experts amongst us to educate us on that topic. I would request, for chairing the session, I would request Dr. Aseem Mehra to kindly take the chair. He's a faculty in the Department of PGI. Next chairperson is Dr. Rahul Chakravarti. He's Assistant Professor in Telemanas, Department of Psychiatry PGI Chandigarh. Next chairperson is Dr. D. Rana. He's Assistant Professor in PGI. I would request our honorable chairpersons to kindly introduce our speakers. That is Dr. Abhisekh Ghosh and Dr. Sopanjit Sahu. Please.
Good morning to all. And the speaker of this session is Dr. Abhisekh Ghosh. He is currently associate professor in our department, and sir is specially looking for the drug de-addiction and treatment center. So sir has a vast experience, sir has a number of publications, has won many awards. So with this I would like to welcome Dr. Abhisekh Ghosh on the dais. The second speaker for the session is Dr. Sopanjit Sahu. So he will talk subsequently after Dr. Abhisekh Ghosh. Sir, please.
Yeah. Thank you very much, Aseem, for the introduction. Thank you. I am one of the organizers, so I cannot thank myself. But, well, there are other organizers, I thank them. I thank all of you who are present here. And I know it's a Sunday morning, and I know there is excellent session which has happened just before that. So that increases my trepidation a little bit, because you know, after a difficult session, you always try to compare how did it go, how did the second session go, how was the first, how was the second session. You know, there is always this comparison. And believe it or not, the speakers is always on the, you know, on the firing line. And well, let us see. So the first, so this is a topic on the criminal justice system. I have a very little work experience in the criminal justice system. Perhaps that's why this topic has been allocated to me, but it's actually has been very challenging. Can you move the slide, Charan, the next one? So there is a QR code here. Please scan the QR code. It will get to you to something which is known as the Mentimeter. So in the Mentimeter, don't click it now. So let them scan the QR code. It will get to the Mentimeter. So there you have a question that when you hear substance use and criminal justice system, what comes to your mind first? So there you have an option of entering 3 words, what comes to your mind first. So now you can click Charan the next thing, because then we can see live what has been entered. Okay, there are already 3 responses. I guess all of you have scanned the QR code, or at least many of you could actually scan that, right? Or we can show that again if you haven't. So can you show the slide again? Yeah, thanks. So please scan the QR code, and this will get to Mentimeter. You know, this will give an idea that what are the expectations from this talk? What do you expect to learn? Because I don't know what is expected. What do you, as a junior resident or maybe a senior resident of psychiatry, would expect to learn from the criminal justice system? So what I have made is based on my own assumption that what you might like to learn. Wow, there's a lot of them. Though these are known as word clouds, all of you know, there are 35 responses. I'm so glad that 35 people are interacting with Mentimeter. Mentimeter will be more happy than me. The software gives you good feedbacks. Well done. Well, NDPS Act is at the center, so that means you know, there are more than 1 responses in the NDPS Act. Those in the center are, you know, there are more than 1 people who responded with that particular response, and those in the periphery are less. So I see SPD, crime, withdrawal symptoms, Indian Penal Code, which has been recently changed, criminal and criminals. Okay, right. So, okay, more prone. Are we still have some responses left, or should we go to the next slide? Sorry, sir, please. Not showing. You have to refresh it. Can you refresh it? So more responses will come. Yeah, there's 119 responses. Wow, that's great. That's quite great. It's fascinating to see. Antisocial takes antisocial is the most common response. So that is perhaps a common myth that people who use drugs and alcohol, perhaps many of them suffer from antisocial personality disorders, and because of this, because of their antisociality, they are more prone to get in contact with the criminal justice system, especially the police and the judiciary, and into the prisons. And that perhaps is the reason why people with drug and alcohol use get into the criminal justice system. So it's not because of their drug and alcohol use, it's because of what kind of person they are. So that is precisely that we are passing a moral judgment on a person's behavior. Here the individual has become more important than the drug itself. The disease has become more important than the moral character of the person. Okay, prison. Okay, we understand criminal justice in the NDPS Act. So a lot of things to do with legality, Indian Penal Code, ASPD again. Antisocial personality disorder is a kind of a medicalized word. Well, somebody has also talked about legalization of cannabis. So we can see kind of a spectrum between, from the criminal justice system to legalization. Criminal justice system legalization is more commercialization, right? So these are two extremes. And the criminal justice system both starts with C, but one criminal justice system is commercial system. But I don't see particularly anything on the health-related aspect. So nobody considers that drug use in the criminal justice system is a public health problem, right? Nobody, at least in this room, has ever considered it's a health problem. Let us look at it from the health lens. Well, so I would agree, I would think that is a very good beginning for me, because then I can talk about something which you might not have thought about, right? So that gives me a hope, right? And perhaps we would then like to listen to the presentation, so that's good. Okay, now you can give the control to me to the slides. Yeah. Thank you, Charan, and thank you those people who are there. Right, so that is what I thought that we can expect. Can we have the lights, please, because anybody can see it, right? Yeah. And it would be great if you have a collar mic, because I like to move around. I'm a bit anxious person, so moving around releases my anxiety a little bit, and it helps. So what can you expect to learn from this presentation? The first one is, why should we be concerned about the criminal justice system, substance use in the criminal justice system? Even when we know the treatment gap, even in the community, is as high as 85 to 90%, why should we talk about criminal justice system? Let us provide the resources for the people who are in the community. So you might be wondering why the Sunday morning. What are the intercepts within the criminal justice system for the substance use, where substance use intervention can be implemented? By intercepts, I mean the windows of opportunity. Okay, so everything has a window of opportunity. So at what level you can do and deliver these interventions, so that you can prevent the harmful consequences of the criminal justice system. As you go ahead, you'll see there are harmful consequences of the criminal justice system itself. Well, that is nothing to do with drugs. Is exactly to do with how the how interaction between the individuals and the structures in the criminal justice system. And why should substance use disorder be implemented in the criminal justice system interventions? Why? That means, what are the evidence in that sense? Okay, finally, if everything is hunky-dory, then why the interventions have not been implemented so far? So what are the problems or the challenges? Okay, so let me start off with a story. This is a story of a fictitious guy by the name Chandu, and he chases heroin. 2 grams per day. He wants treatment, but he suffers from a lot of fear of being caught by police. He also knows that the nearest treatment center is 100 kilometers away from his house in a very remote village in Punjab. So even if he wants treatment, he cannot get into the treatment because that's very far off. He cannot go to the treatment because substance use itself is highly stigmatized. He cannot go and access treatment because he is fearing he might be caught by the police on his way. So what does Chandu do? He continues to use drugs. He continues for some time. Then he was caught by the police and found in possession of 10 grams of heroin. Now many of you are interested in learning a little bit about NDPS Act, but the presentation is not about the Act, but here you can see some glimpses of the NDPS Act. Okay. So the person was booked by the police under NDPS Section 21B. Section 21B can lead up to potentially up to rigorous imprisonment of 10 years because it's more than the small quantities. What he has been carrying, it's more than the, thank you very much. This is more of a stress buster than the mic itself for both purposes. Right, so Chandu was caught by the police. Section 21B was, he was booked under Section 21B, and Section 21B does not provide immunity to the client because it is more than the small quantities of the drugs. So Chandu 21B, 10 years of imprisonment he is looking at, Otherwise, if it has been a small quantity, then Chandu had to agree that he has been taking drugs. Then there is a concept of immunity, that is the 64, Section 64A, and there only one-time treatment provision. Again, this is not a critical assessment of the NDPS Act, so I'll not go there. But Chandu does not get it at 10 grams. Those of you who are clinician who would know, you can switch off this mic, otherwise this will produce echo. So those will know that 10 grams people generally takes 2 to 3 grams of heroin per day. So 10 grams means 5 days of supply. If somebody has to travel 100 kilometers to get heroin, he would get 5 days of supply, right? It's not rocket science to discover that. But with 5 days of supply of heroin, the person is caught as a drug dealer. That is what the XLS, and the person is imprisoned. Okay, fine. Now you might argue that that might be the Indian scenario. What happens in the West might be completely different than what's happening in India, but that's not the case. People who use drugs and alcohol are treated equally means equally badly, I'd say, across the world, because they are seeing through the lenses of a criminal justice system. That we have observed also in the word cloud. We are the reflection of the society, isn't it? What we read in the newspaper, when we talk to people, go to social gathering, what people tells us, our social baggage, our family baggage, that makes up what we are today. So it is no different. It's across the world. You say 30 to 50% people have a brush with the criminal justice system, who use drugs and alcohol have a brush with the criminal justice system at any point in time in their life. The variability is very less. You say 30 to 50%, 50% in the US, 30% in the European countries, because there are several European Union countries, starting from Portugal, who has decriminalized drug use. But the brushes are still there. Even if you have decriminalized drug use, the person will still be caught by police, then will be laid to the dissuasion committees, and then laid to the community. So it's there. But there are various forms of crimes. Now, why is that? Now, try and understand why do they come in contact with it? The first one is the consumptive crime. Consumptive crime is nothing but a product of the criminal justice law. Because if you criminalize drug use, then drug consumption is a crime, and because of that penal code, the person will be penalized. As simple as that. So consumptive crime comprise of people who suffer from drug use disorder largely. Then there is this acquisitive crime. So for acquisition of drug, so I'm a person with a drug use disorder, and I need a lot of drug, but I don't have the money. I go and snatch somebody's purse. So that is an example of accusative crime. So this, you could see that is in yellow color. So because when somebody decriminalizes drug use, they do not usually decriminalize the acquisitive part of the crime is a consumptive crime, which is decriminalized. Then there is drug-induced crime, which does not fall into the category of substance use disorder at all. People who deliberately use drugs to reduce their social inhibition and do there. So terrorists do it. So this does not come under the purview of today's presentation at all. The first one does come under the purview of the presentation. That's the consumptive crime. Neither the accusative crime, nor the drug-induced crime, nor the next one, the supply-related systematic crime. These are like criminal nexus. Okay, these are definitely criminal offenses to supply drugs and all. But what I am talking about today here is the consumptive form of crime. People who use drugs and alcohol in some states as well. Okay, now let us just concentrate on this figure a little bit. There are 3 colors, so I don't think I need to use a pointer. This is the world figure. This is a even disease figure 2024 data set, where you can see that, so there is a violet box, there is a green box or turquoise box who are very specific on color, and there is a green box. Okay, so you could see the violet box as the violet bar is a largest bar. So violet bar is people who are in drug possession or use. So they are the consumptive crime group. They are the people who suffer from drug use disorder, and they come in contact with the police. So this is the first bar is coming in contact with police. Okay. The second bar is about prosecution, and third is the conviction. So in all 3 bars, all 3 different bars, you could see the violet color bar is the maximum, is the largest one. So people who are consuming drugs, alcohol, they are being arrested more commonly, they are being convicted, they are being prosecuted more commonly, and they are being convicted finally. But there is a hope. What is the hope? The number gradually reduces. That means they are initially caught by the police, but they cannot be convicted later. That means they are not drug peddlers. They are not drug dealers. Initially, the police must have thought that they are drug dealers based on the quantities, because criminalization is based on the quantity of drugs. You see, that's the ironical part of it. It's not dependent on the intention, why you are carrying drugs. Nobody will ask you. The amount is 10 grams. So that means you must have been carrying it. So that's the assumption, must have been carrying it for drug dealing. So more often than not, that is not the case. That's why you are seeing the gradual shrinkage of the violet bar, and that is what you are seeing here. Okay, and the next slide, this is just next figure is just comparison of various continents. Again, you could see that continent wise is not much of a difference. Asia is doing better, in fact, as compared to the US, as compared to the other continents. We are better. We are not putting people who use drugs so much behind the bar as does the criminal justice system from the US and the Europe do. So that is a good sign. But you come to the last one, the bottom pie chart, where you could see that the green, the turquoise color is increasing for all the other continents, but not for Asia. So what is happening here is people who are caught, they are also convicted. More often than not, they are convicted. Okay, so that may not be a that good sign. Well, so that is what the fact says. How common? This is not rocket science to figure. This is much more common than community, and because you have already described, there's a lot of association. There's this consumptive crime because you are incarcerating people who already have drug use disorder. So drug use disorder would be more common in the prison than in the community. You can see them in the closed confined space. So how common are they? You can see it's like 30 to 100 times. So you can just imagine the number we are talking about, the magnitude of the problem. Interestingly, drug use disorders are more common than alcohol use disorder. Again, not a rocket science. Alcohol is not criminalized, but drug is, so you have a higher prevalence of drug use disorder. That does not mean people who suffer from drug use disorder are more antisocial than people with alcohol use disorder. Please don't go by the impression. This is just what you are seeing as a reflection of the system by which people are criminalized. People are being criminalized. And there is another interesting thing. Yesterday we have a presentation by Professor Murthy on women with drug and alcohol use problems. You can see here, now if you, the proportion of women who are incarcerated, drug use disorders are more common than men in them. Okay, so that there is again the concept of intersectionality. I haven't presented the data for the different races. That's also very important. If you see that people of colors are more incarcerated, are more vulnerable to get incarcerated. Likewise, the women are more vulnerable to be incarcerated. So that's an example of intersectionality that we have been talking about yesterday. Okay, then what are the other important concerns other than drug use? What if people use drugs and alcohol? How does it matter? You see, prison is a setting where the drug availability is very limited, where the injection, if you are injecting drugs, injection equipments are really limited, and you are living with a lot of other people in a closely confined space. So 1 plus 2 plus 3, bring it together, what comes is high risk injection behavior. So what happens to high risk injection behavior? There is more HIV, there is more hepatitis C, there are more overdoses. Another problem with the prison says what the drug you are getting, you don't know the sources, and you might have, very pure form of drug and more prone to have overdose as well. And you have a very limited detection and treatment facility. So the chances of not only acquiring infection but also transmitting the infection to the fellow people who are in the brush with the criminal justice system is more. But you may say, how does it matter? What if they are very bad people, immoral people, they should die of HIV and hepatitis? What is the big deal with that? But they are the one who will come to the community, isn't it? They will not be in the prison for, after 10 years, Chandu will come back to the community. Chandu has been chasing heroin. Chandu might have started injecting heroin because of the high risk behavior. Then Chandu might acquire HIV, hepatitis C, and that might not have been detected while he is in the prison. He will come back to the community. Then what will you do? You live in the community. Chandu used to live in the prison, but now he is in the community. So all of you are at risk then. If you don't treat Chandu at the prison, or even if you don't intervene Chandu before he gets into the prison, we are all at risk. Those who are fortunate enough to be here today. Okay. Now, what happens to post-incarceration? So it's not only about incarceration. Then you would say, what happened post-incarceration? Now, if you don't provide treatment, you can provide forced abstinence based on the limited supply. You cut off all the supplies, very strict jail superintendent doesn't allow anything to come into. And forced abstinence, the person goes into the community. What would the person do? You didn't provide him with treatment, it didn't equip him with skill, he will go and use drugs. But there is a period of 1 year, 2 years, 3 years, 4 years in between, but the person hasn't used the drug, therefore there is a loss of tolerance, and you know what would be the result of that. Moreover, the reuse can also lead to, because you are talking about consumptive crime, going back to the, so this particular phenomenon is known as recidivism. When people come back, goes to the community and then coming back again. Why it is happening? It is not happening, you see, it's not happening because of the individual. It has happened because there was no intervention. There was an opportunity to intervene at various points in time. I will see that in the next slide. But all those were not done. That's why. So it's a health system failure, it's not an individual failure. Okay, now what are the intercepts? I have promised you that I'll talk about the intercepts. Here is Chandu. The first intercept is when preventing Chandu's brush with police. So you all know that what is the answer. The answer is kind of, decriminalization and so on and so forth. There are various forms of decriminalization. So these are kind of umbrella term is used for that, is known as pre-arrest diversion program, because you are trying to divert these group of divert Chandu from the criminal justice system. Okay, so the classic example of this is a Portuguese decriminalization policy which started in 2003 because of the intense epidemic of HIV, overdose, increased criminal activity in the Portuguese society. So they thought that decriminalization is a very good option, and they did it. And what happened after that? Voila. People around Portugal, the countries surrounding Portugal, thought that this was a disaster. This is going to be a disaster. More people will be using drugs. There will be more HIV. There will be more HIV, and there will be more criminal activities as well. But that did not happen. That did not happen. What happened is just the opposite, exactly just the opposite of it. The rise of the drug use in the neighboring countries in the Portugal, if you compare it, rise of drug use in Portugal was less. Injection drug use, less. HIV, less. Drug use in the young population, because you would expect the young population to take up drug, less as compared to the neighboring countries. So that worked. Well, there is now 20 years have passed. There is a lot of literature, new literature coming up, how it is difficult to implement drug decriminalization. Nobody is talking that this was a failure. This was spoken in terms of how it is very difficult to, continue to persuade the society and the politics behind it to kind of rally behind decriminalization and to continue it, to sustain it. That was the difficult part of it. But decriminalization produced an immediate result. Within a few years, you would see the changes. And that is happening. So that is like, do not arrest people. So what Portugal did is the drug dissuasion committee, which comprised of not only people from the criminal justice system, but also volunteers from drug treatment facilities, and they sometimes they give just fines, sometimes offer treatment, and more sort of community integration, treatment, harm reduction based approach was provided to there. So that is an example of the pre-arrest diversion program. Well, if that does not happen, if the person is brought to the court, then there are drug courts. There are various US drug courts where various drug courts are there in the US. What they do is, again, the focus is on treatment, community reintegration, rehabilitation, and this is there is a concept of probation. So you are on probation. So you are diverted from the criminal justice system to the community, but you are on probation. That's why you will be on continuous supervision by your probation officer, and you will be under treatment, and you will be monitored. You need to appear to the probation officer and to the drug court intermittently or periodically to provide evidence that you are not doing drugs and you are not involved in the criminal activities. That's what the drug courts are all about. There is one treatment accountability for safer communities, which is like more collaborative with the treatment facilities. Drug court is, you can say, is more or less they are the same. Drug court is more criminal justice driven, whereas the other one is more the treatment driven. Now, if those options do not exist, like in our country, there are no drug diversion program, there are no drug courts, what can you do? Chandu gets incarcerated because there are no pre-arrest programs. The first thing what you can do is just treat the withdrawal. Okay, because that's the most difficult part. If you don't treat, say, alcohol use disorder, alcohol withdrawal, the person might have seizure. If you have an opioid withdrawal, it might be very, very distressing for your patient. It's difficult to manage for in the criminal justice system. So treat the withdrawal and then forget about it. Is that a good thing? We have learned about the forced abstinence thing. So it was kind of a forced abstinence. It's a little bit of less distressing type of forced abstinence. and Chandu, when Chandu has the re-entry, this is known as a re-entry to the community when Chandu walks out of the prison, he is not on any treatment. The second option is you provide withdrawal treatment, of course, and you also provide maintenance treatment. But you provide maintenance withdrawal treatment while Chandu is in the prison. Okay, so at least Chandu is good, nicely taken care of while he is in the prison. But what happens after Chandu, goes out of the prison and re-entered the treatment, re-entered the community? What happens then? Again, so we see the lacunae. The final one you could see is perhaps the most important, the most comprehensive program should comprise of not only treatment within the prison, but also a good treatment re-entry option in the community. So whenever Chandru goes to the community, there is a clinic or there are community-based services which are linked with the prison. So as soon as say 1 month before, this is known as pre-release counseling and pre-release treatment engagement, you just contact Chandu make contacts between Chandu and the other treatment facilities, and you make sure that these are connected. Well, that's kind of ideal thing. So if the pre-arrest diversion program drug courts do not exist, you have still an option while Chandu is incarcerated to treat. What else can be done other than the treatment? You can also deliver psychosocial treatment. There is a therapeutic community. What forms of psychosocial therapeutic community? MAT is a medication assisted treatment which comprises of how much time left for me?
Approximately 8 to 10 minutes.
10 minutes. Okay, 10 minutes. Okay.
Less than 10.
सर आपका ऐसे एक्चुअली टाइम हो गया है, वी आर रनिंग लेट.
It started 10:30, so
हाँ, 30 minutes is allotted for speaker, sir.
30 minutes. So
It's-
8 minutes, 8 to 10 minutes?
Yes, sir.
5 to 10 minutes. Yeah, I saw Swapnajit's face and he was kind of worried because he's the next presenter. I understand there is always this, there is this, and I will hate to insinuate on Swapnajit's thing. So, yeah, I'll just skip this part of that maybe. These are the, so you are free to discuss many of these things because, this is an emotive area for me. I have been working in this area for a little time now, and this is, so I tend to speak more in this area. So I just forgive me for that. So let us come to this fact that do these programs work? I have spoken about broadly the programs, right? Do this work? Why should you deliberate if they do not work? Okay. So first let's talk about the diversion program. There is a summary slide for all that. I can straight away go to the summary slide, I think. But overall diversion program works. It reduces recidivism. That's what diversion program is all about. Reducing recidivism. It reduces social cost. Because to maintain a person in the criminal justice system, to put those bars, the iron bars, are more costly than giving them treatment. Believe it or not, people have calculated it. Putting those iron bars, putting all the security staff within the prison is costlier than treating people. So that might sound funny, but actually that is what happens, and that is actually what Portugal done it, and that Drug courts also seem to work, but it works when it's more individualistic. Okay, so that kind of when you have a probation officer who is more engaged, who is from say psychiatry background, a social work background, or mental health background, really committed, try to engage, it works as well. Medication assisted treatment, we know that this is the gold standard treatment, or in the community this is also the gold standard treatment for people who are incarcerated. So of course it works. It does not only work while the person in the prison, it works while the person goes to the community. It increases the rates of treatment entry. If you put somebody on methadone while he's on treatment, the likelihood of that person going to the methadone clinic during the re-entry is more if you don't treat them with methadone or other treatment. And they reduces the risk of mortality. We are concerned about mortality because there is a loss of tolerance, because because there is increased chance of mortality when they go out to the community. They reduce mortality. This one is a retrospective thing, and as per this is almost 50% reduction in the mortality for both buprenorphine and methadone. But if in the next slide, I have a systematic review, which is the most recent one published by the Degenhardt group this month only. And there we'll see the chances, the overdose mortality reduces more significantly, as 75% reduction of mortality. Psychosocial interventions also do work. The work we did with some Haryana prisons, a randomized trial on that. There we provided psychosocial interventions based on an approach of cognitive behavior therapy, simply coping skills enhancement, craving management, stigma reductions. For stigma reduction, we borrowed some concept of acceptance and commitment therapy, and is a kind of 3-session intervention, and there is a package of psychoeducation as well. So as there is a 3-session intervention delivered to a group of people who are in brush with the criminal justice system. And I will not be able to present the result of that because that is under consideration for publication, but the results are positive overall. So psychosocial interventions also do work. If you have, there is a lot of resistance for prescribing this, but so you can still offer something. At least something is better than nothing. You can still offer psychosocial interventions. I think there is not much evidence for the time. The evidence is accumulative for the take-home naloxone. I will skip this slide. And so if MAT works post incarceration, yes, it does. It does not only work while people within the prisons. It reduces overdose mortalities, reduces the chances of reincarceration, and it works more with people who are engaged with MAT. Okay, and engagement again is not the people factor. People is the factor of the healthcare system. Healthcare system should be accommodating enough and flexible enough to accommodate people from low motivation to high motivation spectrum. Okay, so it's that kind of an approach we should be. Peer-based recovery support, it works. It's something like Alcoholics Anonymous, so people who are in the therapeutic community and then they go back to the community and they form their own community. That is the peer community. So again, another person coming from the same prison. So there is a peer-based community and support there as well. Okay, this is the latest article that I have been talking about. This is recently published in the Lancet. So, everything seems to work, and here you could see the therapeutic community is one of the best evidence-based psychosocial treatment for this. Okay, and other than this, OAMT for opioid dependence, for opioid agonist maintenance treatment. So, do these intercept work? Yes, all of them work in to some or less extent, but they work. Drug driver, if talk about diversion program, drug courts, MAT, psychosocial intervention. Then the question is, if these intercepts work, then why Chandu does not get it? What is the problem? We know that there is a problem. We know what is the solution, but Chandu does not get it. So there must be something else we are missing here. So this is the first of the series of publication. I think, as I said, the others I cannot tell here, but this has already been published. So that we have approached this in the form of the qualitative interview. So we have snowballed sample around 20 people who are prison inmates. There are four health administrators and prison administrator and 4 healthcare staffs. Those were interviewed. And we have taken here a health system approach to understand how to bring about people behavior change. So this is a pre-intervention based on which we developed this intervention and tested the intervention, and we did a post-intervention process evaluation later on. So this is known as a behavior change wheel. This, you could see there are 3 layers. So the layer, the thing in the core is the individual. Then the intervention characteristic, and finally you see the policy, the structure. Okay, so say if you have a very highly motivated individual, Chandu is highly motivated to quit drug use. You remember, he wanted to seek treatment, but he went to a prison where there are no withdrawal treatments available. So that's the intervention component of it. And why was there no withdrawal treatment available? Because there was no trained healthcare professional there. So that's the outer circle of this policy. So if we look at just the inner circle, then can you take care of Chandu? You cannot. You cannot. That is rocket science. So you have to take a healthcare systems perspective. You have to think Chandu as an entity who exists in a small entity in the healthcare system. And that is the approach you want. But for that, you need to change the policy. You need to take that's the big thing. So you can just start with the interventions first, and try to interact with the prison administrator, health policymaker, make them more acceptable, make it more acceptable to them. And you cannot just go and tell them I will administer MAT now. It is not possible. But it's like entry, just keeping the door open. I think here we are talking about the main the same thing which I've already described. I'll skip that. So this is my final slide. We know why to offer treatment, right? Because it reduces substance use, because it improves mental health, reduce social overdose risk, and possibly reduce the risk of recidivism. We also know when to offer this treatment. It can be offered pre-incarceration, during incarceration, post-incarceration, all phases. Okay. We also know what to offer: psychosocial intervention, YAMT, but we do not know how to offer it. That's what is implementation science is all about. Okay, so I'll stop here. Thank you very much for your kind listening.
Thank you, Dr. Abhisekh. Wonderful presentation. And there is interaction between criminal justice system, substance abuse, and the substance dependence. You have beautifully mentioned all these aspects and also shared your own experience regarding prison treatment. And congrats. And question answer I think we will take after Dr. Sopanji's presentation.